and this is Azhar. I hope you can all hear me. So I'm meant to teach you about hypo and hyperkalemia. There's nothing much in hypo and hyperkalemia, to be honest. But at the same time, it's very, very important to learn about hyperkalemia because in last professional exam, final year exam, they did put a question for hyperkalemia management, the full question in theory paper for nephrology section. So this is important to know. It's life-threatening problem. So we will learn about how to manage hyperkalemia, and in different scenarios of nephrology you will seeing hyperkalemia. So the management for hyperkalemia should be in your tips. Okay, so it's a 1 hour lecture. So I think I would just say that I would sort of try to make some introduction about now CKD. Remember, we learned about acute kidney injury, and now we're going to learn about CKD. I think it's your last week of nephrology, though, so you already had enough nephrology. So let's go through these couple of cases with different stems. Just to they must have covered a bit of CKD. So during a nephrology rotation, you see a patient in a pre-dialysis clinic. When I say a pre-dialysis clinic, it means that patient has got around CKD stage 4 or 5 or worsening of creatinine, and stage 4, which is going into stage 5. So that type of a clinic is a pre-dialysis clinic, and most likely the worsening CKD4s and CKD5 are seen in pre-dialysis clinics. So Mr. S was a 63 years old man who has a diabetic nephropathy. So the kidney disease was secondary to diabetes. So he had a diabetic nephropathy. He's hypertension. He's got ischemic heart disease, where he was treated with angioplasty and stenting, and he had cirrhosis as well. So an arteriopath with diabetes. So he's got diabetes, he's got hypertension, he's got chronic kidney disease, he's got ischemic heart disease. So thing which is left with him is his brain. So he didn't have a CVA, but I'm sure if you do his CT brain, it will show some sort of microvascular disease because he is an arteriopath. Okay, so go through his medications. Aspirin, 75 milligram orally once a day. So aspirin is why you give aspirin? So you give aspirin for a primary and secondary prevention of ischemic heart disease. This patient already has ischemic heart disease, so you were bound to give aspirin. Simvastatin, which is a statin, lipid-lowering medication, so they are at risk of stroke and at risk of further ischemia, and they give us statins. He's on insulin. He takes insulin for his diabetes. He's in a small dose of ACE inhibitors, Ramifra. He's on bisoprolol 5 milligram, and he's on furosemide 40 milligram orally, and he takes erythropoietin injections subcutaneously once a week. Okay. So he is on a stable sort of medications. So he has blood rechecked by his GP, and he came back. So it's a comparison of a 2 months ago blood test and now. So his blood pressure has been a bit on the overside. So his blood pressure is suboptimally controlled. 152 is higher reading. His weight is almost plateaued. He has dropped his hemoglobin. So he's got anemia. His creatinine is slowly creeping up. And his EGFR is gone down by 3 mils in the last 2 months in a CKD4 worsening patient who has become a CKD5. His bicarbonate is low but hasn't dropped. His phosphate is slightly on the higher side, elevated. His ferritin has become low. His iron saturation has become low. And urine protein creatinine ratio is almost the same. So what you are gathering from this data? Let's concentrate. Suboptimal control blood pressure, more of anemia, rise in a creatinine, decrease in a EGFR, and low iron. So patient has got worsening of kidney function, which has made her blood pressure suboptimal control, which has contributed to his anemia by decreasing his iron. So these are 2-3 abnormalities you have observed by this data. So he's very keen to track his EGFR. And he asks about his level of renal function, so you have to answer. You show him his current EGFR in his last 12 months. So you see that the progression of his chronic kidney disease, the last 12 months, if you see, his EGFR was 21 12 months ago, and now it's 14. So he's upsetting, definitely. He sees it's coming, and is going to a CKD5, more anemic. So we measure EGFR. Okay, so which one of the following is correct regarding measuring of EGFR provides an exact assessment of his renal function? Exact cannot happen because EGFR is an estimated. EGFR are more accurate at lower levels of renal function. Measurement of EGFR should be supplemented with a regular measurement of isotopic GFR. No, so they're more accurate at a lower level of renal function. So that is correct. So EGFR, so is an estimated. This is a formula, you mathematically can derive value. It allows easier comparison between patients, but there are several factors which affect EGFR. Age, what's your muscle mass, and whether you have got any other illness. So in UK they do MDRD. So this is your Ckd stages, okay? So you need to know. So read through this. So you divide Ckd into 5 stages, as you also know, on the basis of EGFR. So G1 is normal EGFR or high, greater than 90. G2 is when the EGFR is 60 to 89. G3 is divided again into two. G3A is 45 to 59 and G3B is 30 to 44. G4 is 15 to 29 and G5 is kidney failure less than 15 and stage renal disease. But now there is albumin creatinine ratio. So you measure ACR. So if it's less than 30 or less than 3 depending on the units, you divide it into A1, A2, A3. So you go with the G1 either A1, A2, A3, G2 either A1, A2, A3. So green boxes are low risk. If the patient has got a G1, A1, G2, A1, they are low risk. Yellow are moderately increased risk. If the patient has got G1 but A2, so proteinuria increases, the problem increases. So yellow are moderately increased, orange are severely increased, and red are at high risk. So all the red patients should be seen by the nephrologist. In other words, patients who have got proteinuria, regardless of the EGFR, they are at high risk of progression of the chronic kidney disease. So let me tell you something about this creatinine thing. So creatinine is generated from muscle mass and is both filtered at the glomerulus and secreted by the tubule. So creatinine value alone cannot be account for filtration because it is secreted as well. So when there are drugs which compete with creatinine secretions, they increase the creatinine without any glomerular EGFR being affected, causing an apparent fall in the EGFR. So they will increase the creatinine because they are creatinine competitors at the secretion level. So the EGFR is falsely low. Muscle mass is lost in critical ill patient, so drop in creatinine generation. So then one is the MDRD equation, and the other was a CKD API equation, which is the epidemiology collaboration equation. More accurate at higher level of kidney functions. So people are trying to use a cystatin C instead of a serum creatinine. So CKD is a biochemical syndrome, it's not a diagnosis. So chronic kidney disease is not a diagnosis. You can't label someone with renal failure with a CKD. It's a biochemical syndrome, just like a metabolic syndrome. To diagnose the patient with a CKD and EGFR is 45 or a cystatin of 60 on two separate occasions. Okay. So you explain them the results and you took a look at his current blood pressure. According to the NICE guidance, which one of the following is going to an appropriate target blood pressure for him? There is no clear blood pressure targets in CKD4/5. The blood pressure target for this patient is less than 140/80, less than 127/80. So I think it's less than 130/80, but it could be 120/70. This patient has got a diabetes and got a proteinuria and got a CKD. So that's correct. So let's see about what CKD and the blood pressure target says. So there is strong data supporting treatment of hypertension and CKD in patients without diabetes and low levels of proteinuria. The target blood pressure is 140/90. The target blood pressure is 130/80 in patients with diabetes or those who have heavy proteinuria. If you decrease the blood pressure much lower, there's an increase in the mortality. So ACE inhibitors, there's a ramipril. So previously they used to stop the ACE inhibitor used to decrease the progression of the renal disease in diabetes and a proteinuric patient. So you check the renal function before starting it and you recheck it after 2 weeks. If you start or increase the dose of diuretics and your ACE injury. An increase in serum creatinine up to 30% or a fall in EGFR 25%, you discontinue ACE inhibitors. Dual blockage with ACE and AR2 should not be used routinely. So the kidneys must secrete some medications which for medications to be effective. So kidneys are important metabolic area for the metabolism of the medications and the function, the kidney function. This can be problematic, such as thiazide and nitrofurantoin. So if the patient got dialysis, you do the timing of the dialysis treatment that the medications cannot be cleared out. So opioid, you need to dose reduction, several sort of antibiotics, you need to decrease the doses if the patient has got acute kidney injury. Or if someone has got a degree of renal impairment, the doses may need changing or drug stopping as patients develop progressive CKD. Okay. So during the consultation, he's becoming more fatigued and easy on exertion and becoming more weak. So you noted anemia before. He doesn't have any problem with his appetite or any dyspepsia. His bowel habit has not been changed. So these are the tips to see whether he has got any bowel pathology to be accountable for his anemia. But he doesn't have. So patient doesn't have a dyspepsia, no swallowing problems, no changes in bowel habits. So anemia is most likely a renal anemia. Heart sounds were normal. There's a bit of mild edema, abdomen soft and non-tender. So you think that the patient is anemic, and his ferritin was low. Which of the following is correct regarding the next step in the management of his anemia? So you give a blood transfusion. The dose of erythropoietin to increase. He should be prescribed an oral iron. He should be prescribed an intravenous iron. He should be referred for upper and lower GI endoscopies. Okay, so the dose of erythropoietin should be increased not to aim the hemoglobin of 13. This is too high. Oral iron absorption is far less in CKD5 patients. Whether he should be prescribed, I don't know. It depends upon which guidelines you're following. Both can be corrective. But I will do this because oral absorption is not great. So this is regarding anemia management in CKD. We did a hypertension management. This is the anemia management. So blood transfusion in dialysis patients or in CKD patients, you need to think about whether these patients need any renal transplant in futures, or they are the candidates of renal transplants in future. Because they are a candidate and you give repeated blood transfusions, it's a highly antigenic load in the blood, and this can make antibodies, and the patients can be deferred for the transplantation. So the anemia related to CKD are managed with iron and erythropoietin, both. So if you aim for the normal reference range of hemoglobin, that causes increased cardiovascular mortality. So you need to keep the hemoglobin just below the level. So normally most of the guidelines is between 10 to 12. So what your aim is to relieve the symptoms. CKD is an inflammatory state and ferritin levels are higher in patients in CKD than in general population. So if the ferritin levels are between 200 and 500, they are deemed iron sufficient. So you do other measurements such as typically transferrin saturations or a percentage of hypochromic red cells. So if the ferritin levels are 100 or lower, ferritin levels between 100 and 200 with low transferrin patients are deemed functionally iron deficient. Has 142, the anemia would benefit with iron supplementation prior to titrating erythropoietin. Oral iron is less efficacious. So so in CKD 3 you give oral iron, while the patient goes CKD 5. 4 is a borderline case, but 5 you give intravenous irons. SCARS is a Stevens-Johnson syndrome and epidermal necrosis. So patients who have got recombinant erythropoietins, they can have SCARS reactions. Patients should be told for that. Okay. Question number 4. So we did anemia, we did hypertension. Now there's something else is coming. Patient has taken a close interest in his blood results tracks. This is an online resource, and he sees his blood results, and he came to know his phosphate is on a higher side, and his calcium is within normal range, his PTH is on a higher side as well. So normal calcium with high level of PTH is primary hyperparathyroidism. No. High PTH and phosphate suggest the patient has got secondary hyperparathyroidism. Refer for dietetic advice. Should be prescribed a phosphate binder. Prescribe non-calcium phosphate or a calcium phosphate binder. Or you should prescribe a sinacalcet. So this patient has got PTH and high phosphate suggests your secondary hyperparathyroidism. So initial step is a dietary advice. So let's go through this. So high PTH and phosphate suggests that this patient has got secondary hyperparathyroidism. So renal bone disease, one thing is a secondary hyperparathyroidism. Initial management for that is what? The initial management for this is dietary advice. So the kidneys are responsible for 1-alpha hydroxylation of vitamin D, which is an essential step in making an active compound. The resulting reduction in active vitamin D results in hypocalcemia unless there is an increased parathyroid activity. Phosphate excretion is reduced in Ckd, and hyperphosphatemia has direct action on the parathyroid gland. These factors increases the reduced calcium absorption, leading to secondary hyperparathyroidism. So let's go through this. So kidneys, low active vitamin D, calcium absorption is decreased. PTH has got indirect effect. Increased PTH promotes urinary phosphate loss. And it is a reduced phosphate excretion that will increase the PTH again, and which increases the release of bones. So increased phosphate levels are strongly linked with an increase in mortality. CKD patients who runs a high phosphate levels, they have got a high cardiovascular mortality. And they are a surrogate marker for vascular calcification. So NICE recommends dietary control of phosphate intake. First line step. So you refer for the special renal dietitian. If inaccessible, then you start with the calcium-based phosphate binders, which are cheaper. Followed by a non-calcium based. So cinacalcet is reserved for the severe cases. So potassium, phosphate, and sodium levels in food are important factors of patients in CKD to be aware of. So anything which is tinned, beans, ready meals, all have high in sodium. Prawns, smoked salmon, some fish, processed ready meals, milk have got high phosphate levels as well. Bananas have a repetition of high potassium. So dietary advice is very important for this. Okay. So you're given him an opportunity to ask questions, and he is going to ask you a question. He recently booked a holiday and cost insurance and tell, what are you going to explain him? What will happen? Long-term survival. Prognosis. So his cardiovascular risk increased to twofold, threefold. Cause of renal failure has got regulated on prognosis. Starting dialysis will reduce his risk of cardiovascular disease? No. So it's probably got a threefold risk, I think. So prognosis, cardiovascular risk factors. Risk of death significantly elevated in CKD. The later stages of CKD has got a higher risk. The risk of cardiovascular is more than 3.3 times more with EGFR of less than 15. So long-term prognosis is poor, they live short. The cause of renal failure is irrelevant when you reach the stage 5. 2% of the population of CKD will progress to the dialysis each year. So 10 में से 2 जो हैं वो उनकी dialysis होती है. Cardiovascular events decrease कर जाते हैं after renal transplantation. So renal transplantation is a good treatment for the CKD. Just give me 1 second. जी अस्सलाम वालेकुम, मैं लेक्चर में हूँ, मैं 1:30 बजे आपको देखूंगा, आप मेरे कमरे के बाहर चले जाएं। तो CKD की कॉजेज़ क्या होती हैं? डायबिटीज़ है, वैस्कुलर डिजीज़ हैं, हाइपरटेंशन हो गई और यहाँ ग्लोमेरुलोनेफ्राइटिस है, पॉलीसिस्टिक किडनी डिजीज़ भी है, IgA नेफ्रोपैथी भी है। Okay. So what are the key points? So EGFR is used to diagnose and monitor CKD. Creatinine is used to diagnose and monitor acute kidney injury. MDRD equation is most of the time it's used, but there is another equations like API equation. 1 to 5 stages होती हैं. Hypertension control करना बहुत ज़रूरी है. Non-diabetic और non-protein uric less than 140, diabetic और protein uric 138. ACE inhibitors number 1 options हैं अगर diabetes हो या protein urea हो. Anemia को मैनेज करते हैं erythropoietin से और iron supplementation से. Hypercalcemia हो सकता है, hyperphosphatemia हो सकता है, hyperparathyroidism हो सकता है. CKD से death rate increase होता है, general population के लिए 2-fold, 3-fold increase होता है depending upon the stage of the CKD. Okay. Should we see if we can just go through the hypokalemia before I do the case 3? I think so. So new share, this one. Okay, so main talk about hypokalemia and hyperkalemia. So let me talk about hyperkalemia first. You don't need to need all these things though. If you go through these 2 slides, you will be great. Okay, hyperkalemia. First, you need to know whether it is a spurious or it is a genuine. So when people take blood, they don't release the tourniquet, they keep it tight, and the blood cells get damaged. So ischemic blood draws, prolonged use of tourniquet, RBC cells get hemolysis in test tubes, and if there is a lot of leukocytosis and thrombocytosis, that can do this with maybe a hyperkalemia, the spurious. So a metabolic acidosis will shift the potassium outside. So what are the drugs which can cause metabolic acidosis? Insulin deficiency. Beta blocker can cause metabolic acidosis. Tissue breakdown, rhabdomyolysis, tumor lysis, intravascular hemolysis, drug toxicity, or is a chronic hyperkalemia, such as in CKD when the patients develop acute chronic hyperkalemia. So acute hyperkalemia happens when there is a transcellular shift, and such as in metabolic acidosis. Okay. So in a professional examination, the majority of the questions which they ask you about hyperkalemia, that the patient has got a worsened CKD, or there's a dialysis indication for hyperkalemia, or the patient has got a rhabdomyolysis. So chronic hyperkalemia, metabolic acidosis. So hypoaldestrianism, when there is a primary adrenal insufficiency, when you give ACE inhibitors. So it is a hyperrenemic hypoaldosteronism, which happens in diabetic nephropathy, or NSAIDs, or chronic tubular interstitial nephritis. When there is a hyperrenemic hypoaldosteronism with high blood pressure, which caused by the Gordon syndrome, cyclosporine toxicity, or type 4 renal tubular acidosis. If there is a hyperaldosteronism and hyperenemia with decreased blood pressure, it means either patient is taking some medication which is affecting on the renin system, such as spironolactone, eplerenone, increase in the aldosterone, then increase in the renin level with decreased blood pressure. So hypoaldosteronism. What causes hypoaldosteronism? NSAIDs, chronic tubular interstitial nephritis, renal failure, hyperpotassium sparing diuretics, which we have already discussed. So what will you see in ECG? Tall peak T waves, earliest change. The QT interval is getting shortened. The QRS complex gets wider. PR intervals prolonged, second degree or third degree heart blocks. P wave amplitude is going low. Sometimes a complete loss of P waves, Q waves widened, ventral shuttle-like pattern, and eventually asystole. So tall peak T waves, earliest changed. Short QT interval. QRS widened, sine wave pattern, eventual asystole. So what do you do? Restrict potassium intake. Stop potassium supplements. Stop potassium sparing diuretics if any. But these are for the chronic stable hyperkalemia. In emergency, there are different treatments. To stabilize the cardiac membrane, you give calcium gluconate for 1 to 3 minutes, and you repeat if the ECG changes has not settled. You give insulin 10 to 20 units, and you give IV glucose. You give sodium bicarbonate and dextrose water. Give nebulized beta-2 agonist. So you need to remember this treatment. Diuretics will also take the potassium out. And sometimes you give resins, such as retention enemas. You give calcium, potassium binding resins. And if the potassium does not settle down with all the conventional treatment, there is a life-threatening hyperkalemia, you do hemodialysis. Peritoneal dialysis is far less effective than hemodialysis. So that's the slide for the hyperkalemia. If you want to go through in the next couple of minutes, you can go through, and then I'll talk about hypokalemia. Okay. Again, hyperkalemia, whether it's a spurious WBC uptake of potassium in a test tube, which is extreme leukocytosis and cancers and blood cancers, it causes hypo or hyperkalemia. Transcellular shift, if the patient potassium has gone inside the cells. Just give me 1 second. Yes, Assalamualaikum. कौन बोल रहा है? अच्छा अच्छा, मैं अभी ना इस वक्त लेक्चर के दौरान मैंने अभी हॉस्पिटल जाना है, उनको देखना है, तो फिर मैं आपसे बात करूँगा, ठीक है? हाँ, अल्लाह हाफ़िज़। So, drugs, insulin, you give in the treatment of hyperkalemia, beta agonist, you give in the treatment. Anabolic state, B12 or folate treatment. Hypokalemic periodic paralysis can happen, decreased total body potassium if there is dehydration. So renal losses or extra losses, extra renal losses. So if there's extra renal loss, the urinary potassium is low if there's an extra renal loss. If there is a metabolic acidosis, diarrhea, more metabolic alkalosis, vomiting, diuretic use. So urinary potassium, you check urinary potassium after hypokalemia. Urinary potassium more than 20, it's a renal loss. Primary or secondary hypoaldestrianism. There are few syndromes, Bartter, Gitelman syndromes. Metabolic acidosis can cause renal loss. Metabolic alkalosis can cause renal losses. So Cone syndrome, primary hypoaldosteronism, hypertension with low potassium. In cirrhosis and congestive heart failure, in hypertensive states. So metabolic alkalosis, hypokalemia. So when you see hypokalemia, you need to know the blood pressure and you need to know the pH. So Bartter, Gitelman, chronic vomiting, diuretic abuse, hypomagnesemia, their blood pressure is normal and there is no edema. So metabolic alkalosis, hypokalemia and hypertension. So Little syndrome and a Cushing syndrome. Licorice injection. Dry hydrocorticosteroids treating tumors. So this was with a low blood pressure. So Bartter syndrome, Gitelman syndrome, Diuretic, hypermagnesemia, chronic vomiting. They give a similar picture. So Bartter and Gentleman syndrome, they have got problems in the tubules and other ions as well. So what are the Ecg changes? So flattening or inversion of T waves. T waves get flattened with ST depression. Prominent U waves, prolonged QT. Prolonged PR interval, wide QRS complex, atrial and ventricle tachycardias, and they get predisposed to digitalis toxicity. So neuromuscular weaknesses, cramps, glucose introlysis, ghost retardation. Treatment, what do you give? You give potassium bicarbonate for chronic diarrhea and RTAs. Central vein, you can give less than 60 millimoles per liter, and in peripheral vein less than 40. Rapid infusion unless there is a paralysis. A rate of infusion less than 20 millimoles an hour. So you don't give a very rapid infusion. So you monitor with the neuromuscular symptoms, ECG, plasma concentration. Sometimes patients have to be put on long-term potassium sparing agents. This is an algorithm if you want to. I will look through this. Any questions you want to ask for me? Okay, if there is no question, I shall leave.